And I'd like to introduce our moderator, Dr. Singh Pallet. Dr. Pallet is a physician and certified medical director, serving as medical director for Optum Senior Community Care in Colorado. She works with advanced practice clinicians in long-term care settings and precepts medical students, residents, and fellows. Dr. Pallet is the president of the Colorado chapter of PALTmed and the chair of PALTmed's Transition of Care and Clinical Practice Committees. With that, I'll turn it over to Dr. Pallet.
Thank you, Jasmine. I'm very pleased to introduce our panelists today, two of them. Starting first with Sharon Huerta. She is a clinical nurse specialist with a Doctor of Nursing practice degree from Johns Hopkins University and a specialization in heart failure management. Currently, she serves at Baptist Memorial Hospital in Memphis, Tennessee as the leader of the heart failure program. This program has won the Get With the Guidelines Heart Failure Gold Plus Award and achieved heart failure accreditation through the American College of Cardiology. Nicole Orr is an assistant professor of medicine in the Division of Cardiology at Tufts University School of Medicine. She is the founder and president of Post-Acute Cardiology Care. Her work is dedicated to developing heart failure disease management programs in skilled nursing facilities. She speaks nationally about geriatric cardiology patients and has published her work regarding best practices for post-acute heart failure management. Why don't we go ahead and get started? Sharon, we would love it if you could start us off with an overview of how you define heart failure.
Sure. So as an introduction to heart failure, the universal definition is a clinical syndrome where abnormal heart structure or function leads to signs and symptoms which are confirmed by a high BNP level or evidence of pulmonary or systemic congestion, commonly known as volume overload. The American Heart Association classifies heart failure into 4 stages, which are seen here. Stage A means you have risk factors like high blood pressure or diabetes, but your heart is still working fine. Stage B means your heart shows some damage, maybe from a past heart attack, but you don't feel any symptoms. And then stage C, your heart damage is now causing symptoms such as feeling tired or short of breath. And this is generally the stage when patients seek treatment and end up in the hospital. And then stage D, your heart failure is severe and you need special treatments because standard ones aren't enough. There's also the NYHA classification, which is similar to the stages for heart failure, but it's numbered 1 through 4.
Thank you. And what about those acronyms like HFpEF and HFrEF?
Sure, yeah. So heart failure is also classified by ejection fraction, which is the percent of blood being pumped out of the heart with each beat. HFrEF is also reduced ejection fraction. That means the heart pumps less than 40% of blood with each beat. HFIMPF, or improved ejection fraction, means the heart previously had a reduced ejection fraction, but it has improved significantly over time. And then HFMRF, or mildly reduced ejection fraction, is when the ejection fraction is between 41 and 49%. And HFpEF, or preserved ejection fraction, means the heart pumps 50% or more, but its filling function is impaired.
So today we're talking about care transitions. What do we know about patients going from the hospital to a skilled nursing facility who have heart failure?
Between 18 and 24% of patients admitted to the hospital for heart failure exacerbation are transferred to a skilled nursing facility at discharge. Common characteristics of patients that go to a SNF rather than to home include those with an extended hospital stay, older age, female gender, low blood pressure, uremia, high ejection fraction, and the presence of the comorbidities of depression, stroke, anemia, diabetes, peripheral vascular disease, COPD, and asthma. Patients with heart failure that are discharged with SNFs show higher 30-day and 1-year mortality rates, as well as higher rehospitalization rates compared to those who go home. This is related to these patients often have had more complex and longer hospitalizations and more challenging to manage comorbidities.
Thank you for highlighting that difference. In 2022, the American Heart Association, American College of Cardiology, and the Heart Failure Society of America updated the guidelines for the management of heart failure. Sharon, at this time, can you give us an overview, please, of those guidelines?
Sure. So for patients with stage C or D heart failure and an ejection fraction of less than 40%, the step 1 of treatment means starting the foundational medications recommended by the guidelines. This involves initiating GDMT or guideline-directed medical therapy and using diuretics as needed for managing symptoms related to fluid overload. The combination of these medications is aimed at improving survival and reducing hospitalizations and managing symptoms. So there's the heart failure guidelines have guideline-directed medical therapy or GDMT, which is also called quadruple therapy and includes 4 classes of medications. So there's a beta blocker, and there's 3 beta blockers that are evidence-based for heart failure: carvedilol, metoprolol succinate, and bisoprolol. And then there's angiotensin receptor neprilysin inhibitor, or ARNI, which is sacubitril/valsartan. This class of medication combines an angiotensin receptor blocker with a neprilysin inhibitor to reduce fibrosis of the heart muscle. And then there's the mineralocorticoid receptor antagonist, or MRA, which is spironolactone or eplerenone. And then the SGLT2 inhibitor, which is dapagliflozin or empagliflozin. And these medications work together to improve symptoms, reduce hospitalizations, and lower mortality in heart failure patients. And research shows that when used together, these medications reduce the risk of death by 73% over 2 years. Heart failure guidelines, consensus statements, and clinical experts now advocate for in-hospital rapid sequence initiation of core GDMT, including all of these medication classes. This is why we try to make sure that all patients with heart failure are discharged from the hospital with quadruple therapy or as many elements as they can tolerate.
Well, as a geriatrician, what I hear you saying is that if we have a patient who has heart failure and they're, say, on a low dose of metoprolol succinate and they're tolerating it well, the next step might be to add a low dose of an additional medication instead of increasing the first medication. Is that correct?
Exactly. So the beneficial effects of each GDMT class are independent of the other classes. And best practice is to prescribe a low dose of each class of medication to reduce mortality and morbidity risks. The additive benefit of adding another GDMT class is greater than the benefit of titrating to the goal dose of an individual class. The benefits of GDMT can be seen as early as 12 days after initiation. A prescription at the time of hospital discharge increases the likelihood of chronic medication adherence, and delaying quadruple therapy comes at the cost of preventable deaths and hospitalizations. Each class of medication in quadruple therapy adds its own unique benefit, and when combined, their positive effects are greater than using any one drug alone. Each class of medication has shown a relative risk reduction in death and heart failure hospitalization.
This is really important. And these additive benefits are kind of a shift for many prescribers. Can you tell us more about it?
Right, yeah. So simultaneous initiation and continuation of each medication may improve tolerance, adherence, and persistence to the quadruple therapy regimen. So tolerability can be further enhanced by initiating medication at low doses. And then up titration of therapies is not necessary to achieve a reduction in adverse outcomes. Or in other words, even at low doses, patients have reduced hospitalizations and death than when not prescribed at all. An example of how these medications work better together would be switching from an ACE inhibitor to an ARNI decreases the risk of hyperkalemia, which improves tolerance of the MRA. And then the SGLT2 inhibitor may decrease the risk of hyperkalemia and also slows the progression of kidney dysfunction, which enables continuation of the ARNI and the MRA therapy. In other words, each GDMT class has a treatment effect that is independent of dose or prior initiation of other therapies. Low doses of each of these pillars of quadruple therapies have additive therapeutic efficacy, and initiating low doses of all 4 categories of quadruple therapies should be prioritized over strict sequencing and dose escalation, which was historically recommended. There is no available evidence that delaying initiation of any pillar of quadruple therapy accomplishes anything beneficial or improves medication tolerance. Deferring initiation of life-saving medication to the outpatient setting carries a greater than 75% chance that therapy will never be restarted within the next year. And delaying initiation exposes patients to excess risk of clinical worsening and death, and the possibility of never having the medication prescribed at all.
We certainly want these benefits for our patients. Can you tell us a little bit more about the management of HFpEF, the preserved ejection fraction?
Right, yeah. So historically, treatment guidelines for HFpEF have not been well established like they have been for HFrEF due to diagnostic challenges, the high burden of comorbidities, and limited evidence-based therapies. However, the recent emergence of SGLT2 inhibitors has provided significant advancements demonstrating benefits in reducing heart failure symptoms and hospitalizations for patients with HFpEF. Current guidelines also emphasize a comprehensive approach, including optimal management of comorbidities such as hypertension, atrial fibrillation, and diabetes, as well as lifestyle interventions like exercise and weight management and sleep apnea screening and treatment.
Well, thank you for talking about the GDMT and quadruple therapy. Let's say a patient has reached a point in their hospital stay where they're now able to be discharged. Maybe they're going back to their home in the community or to a post-acute facility. What steps need to be taken?
So to prepare the patient from the transition out of the hospital, we should be focusing on patient education with an emphasis on self-care and optimizing medication adherence, and then ensuring evidence-based heart failure pharmacotherapy is prescribed, and providing streamlined communication with the care delivery personnel, such as the family member or the caregiver. When a patient is transferring to a SNF, there should be heart failure specific clinical documentation and communication, which would include things like the discharge weight and ideal weight, and then trends in the hospital for their weight, current vital signs and blood pressure goals, what type of heart failure do they have, and what's their ejection fraction, what is their NYHA classification, current lab values and recommended follow-up lab tests, and then current physical assessments, patient-specific management recommendations, comorbid illnesses, and expectations and goals for clinical and functional improvement.
That's quite a list. Let's go to the next slide here.
So the most important of these would be the ones highlighted here.
Sure. Thank you for highlighting that clinical data. Before we go on to the next slide, let's turn to our experts in the audience. We'd like to create a chat waterfall. We'd like you to think about this next question. Type your response in the chat box, and when I say go, hit return, and then we'll see everyone's answers at once. Here's the question we want you to consider. What critical hospital events need to be included in the transfer information when a patient with heart failure discharges from the hospital? So go ahead and put your answer in the chat box, and when I hit go, you can submit it. Here's the question again. What critical hospital events need to be included in the transfer information when a patient with heart failure discharges from the hospital? Jasmine, I can't see the chat box very clearly at the moment, so we'll count on you to look at them too. But at this time, why don't you go ahead and submit your answers. Ready, set, go.
Quite a few submissions coming in.
And now I was able to open my version of the chat box, and we've got some excellent things that people need to know during this transition. Yep. Thank you. Yeah, medications, weights, goals of care. Any surgical interventions. Current EF, weight class, that ejection fraction, everyone wants to know that. What is the function? Any procedures? What's the dry weight? Critical lab values, excellent. What about the tolerance to medication? Yeah, thank you. We knew that we would generate a lot of excellent responses. On the next two slides, you can see a list of these things, and I think we've covered many of them. decisions and events during the hospitalization, patient and family discharge instructions. I think our audience has caught many of these critical pieces of documentation. We also include this slide about the care plan for the first 30 days after hospitalization. Any comments, Sharon?
Well, I think we can continue on to the next slide.
Absolutely.
So for goals of continuity of care, ideally, we would like for the heart failure GDMT that was started in the hospital to be continued, lab values monitored for potassium and kidney function, and the vitals monitored for medication tolerance. And then symptom monitoring, we would want to include watching for edema, weight gain, worsening shortness of breath, and difficulty breathing when lying flat or increased confusion. And then the cardiology follow-up appointment is important for optimization of GDMT and symptom monitoring, but there should be a consideration on an individual basis if it benefits the patient to leave the facility to go to that appointment or to hold off on it. Is transportation available for that appointment? Is telehealth an option for that appointment? And then the patient likely has forgotten all of the heart failure education that we gave them in the hospital. So helping to reinforce the purpose of the heart failure medications and dietary recommendations and other self-care needs is really important. And then also discussing with the patient goals of care. How much intervention do they want? And are they appropriate to start talking with palliative care or hospice? If they are refusing or don't qualify for advanced heart failure therapy options, it's important to have these discussions rather than continuing to have the patient go back to the hospital multiple times. There was a small study done over 20 years ago, but it's still likely relevant today that communication between providers is really important. And this one hospital found that phone calls from the hospital case manager to the SNF nurses within 48 hours of hospital discharge to review specific aspects of heart failure care, like weights and dietary restrictions, diuretic use, and discharge plans, helped to demonstrate a reduction in average rate of hospital readmission from the SNF back to the hospital from 30% to 11%. So communication with providers is really important.
Thank you. I definitely see every warm handoff as a gift, and we would love to just emphasize that importance of communication. As Sharon mentioned, patients transferred from the hospital to the skilled nursing facility, or SNF, often face unique challenges. Nicole, when you're wearing your hat as a cardiologist on the SNF side, when a patient arrives, what is the first thing that you do?
I try not to panic. And then, well, I think it's important to step back and frame the, what the really important things that Sharon highlighted. And thank you for that excellent introduction, that we need to understand that the patients are very sick and they are a unique demographic. They are selected for skilled nursing facility admission because their recovery needs are really complicated. So on the background of having patients who are older with multiple chronic conditions, geriatric syndromes, frailty, cognitive impairment, and multiple comorbidities that can interfere with their heart failure management, we need to understand first that the patient coming in to a skilled nursing facility with heart failure is among the highest risk patient that we see. And we, the concept of having optimized heart failure management in the hospital before discharge is really what we strive for. But in practicality, what we see is oftentimes it's not possible or it's not optimized. We have patients who are admitted for heart failure or diuresed and then develop acute renal injury, get IV fluids, which is given a day or two before SNF. And by the time they come to us in the skilled nursing facility, they're still not euvolemic. So they might still have residual volume overload on arrival to PAC. So we don't really get the patients when they're in their euvolemic stable state. So we have to understand that there's probably still a lot of work to be done in this recovery process. And some of the common scenarios we need to look out for is that when patients are admitted after discharge, we see from a hospitalization where there were initiation of these cardiac therapeutics, sacubitril/valsartan, the SGLT2 inhibitors, we can't predict how robustly they're going to respond in terms of natriuresis, diuresis. Will they need to maintain their loop diuretic dosing? How quickly are they going to respond from a volume status and volume target perspective in the skilled nursing facility? And we have to really be aware that their condition and their clinical status and volume status is likely going to change within the first 1 to 2 weeks. We also don't quite know when patients who are prescribed these recommended guideline therapies in the hospital, how they're going to respond in rehab. And what I mean by that is oftentimes the medications are prescribed at a patient who's resting in bed and might have a different tolerability at rest than when they're asked to get up, perform, exercise, and really optimize their physical functioning in the recovery process. So symptoms of dyspnea, fatigue, orthostasis might not be elucidated when prescribing the medications in a resting patient hospitalized in a hospital bed. And we don't really understand how they're going to respond to those side effects of medications until we actually have them get up and go in the rehab session. So I think the first thing I do is sort of frame the patient, understand, what is their risk, and be prepared for changes.
Thank you. Yeah, as Sharon mentioned that it can take 12 days to see benefits from these new medications, but it sounds like it also takes a period of time to watch for those side effects.
Yeah, exactly. And we don't really know what to expect from the patients in terms of how they're going to respond to these newly initiated therapies. And then the other thing to consider is that in the post-acute care setting, very different from the community setting or the hospital setting, there's this sort of inherent tension between the cardiocentric goals of heart failure management and rehabilitation goals. And so it's important to understand that optimizing cardiovascular therapeutics, such as maintaining or achieving euvolemic status, cardiac stability, and titrating guideline medical therapy might not be synergistic with optimizing function for timely discharge from a skilled nursing facility. So we need to focus on recovery, getting patients out of the skilled nursing facility, optimally back to their community dwelling if possible. So they need to have optimized energy, blood pressure response, chronotropic response. And so oftentimes there's this tension between optimizing their function and titrating their guideline-directed medical therapy. So I will say, just like this quote, the only thing that is constant is change, is that we can expect that when patients come from the hospital, we really don't know how patients with heart failure who are selected for SNF admission are going to respond. And if I can leave the audience with anything, it would be that when you see a patient coming who has multiple comorbidities, high risk for readmission, has been initiated on guideline-directed medical therapy, it's important to understand that they're not necessarily going to look like they did when they arrived from the hospital. Those medications that were prescribed are not going to be the ones that they need throughout the entire SNF stay. Their volume status may change more quickly than predicted. Their blood pressure may fall or not be optimized unexpectedly. And so the only thing that we can really say with certainty is that the patients who come in will need to be monitored, because change in their status is more likely in this particular cohort than is the status quo and stability.
I think providers would like to be able to keep up with those changes. Nicole, what do you recommend for providers who are observing some concerning changes? They're worried that the medications may not be the right ones, but may not feel comfortable changing medications that a cardiologist prescribed.
Yeah, it's a great question. And I think, in general, it depends on the comfort of the provider. I think there are some straightforward scenarios, increased diuretic dosing if there's residual volume overload, and deprescribed if there's evidence of azotemia or clear dehydration. Adjust antihypertensives as needed, increase rate control if a patient is in atrial fibrillation and tachycardic, or decrease rate controlling agents if they're bradycardic. I think more complicated scenarios are things like chronic kidney disease, patients who you are questioning whether or not to resume an ARNI or an SGLT2 inhibitor that was held on discharge because the patient developed acute kidney injury, or maintaining guideline-directed medical therapy for patients with low cardiac output in the setting of severely reduced LV systolic function. Oftentimes those patients their medications are held out of concern for the providers, dropping their blood pressure, but actually in those patients, what they need is actually a guideline-directed medical therapy and not to consider the medications as antihypertensives. I think, we also often consider, optimizing rate control. Some patients might need different parameters for rate controlling of atrial fibrillation, which is a common comorbidity. And I think whenever there's a question about something more complicated, and you're not sure whether to prescribe or deprescribe, that is when it's probably a good idea to request help from either the nephrologist, the cardiologist, or whoever was involved in the care of the patient's complex comorbidities and managing their heart failure in the hospital. I think it's also important to mention that not all dyspnea in heart failure patients is related to volume overload in a patient who had a diagnosis of heart failure. And I've talked about this at several other occasions, but it's important to note that patients who develop dyspnea, just keep in the back of your mind, they could be cardiac comorbidities or other not related to high feeling pressures causing dyspnea, but an anginal equivalent, hypertensive responses to exercise, comorbid lung disease. They could be having symptomatic chronotropic incompetence, so not able to mount an adequate heart rate response to exercise because of their dosing of beta blockade. They could be deconditioned, suffering from frailty or sarcopenia. So understanding that not all dyspnea is related to volume overload in heart failure patients is really important. And if someone's not responding once they've reached euvolemia, to really look further into that, because the dyspnea is going to be something to prompt readmission and often diminish functional progress in physical therapy. And finally, we understand that there are many challenges in setting up outpatient clinic follow-up because of logistical concerns, staff availability, family reluctance to have the patients leave, holding diuretics, just the logistical concern of being gone for several hours in a skilled nursing facility with covering staff. And it's important to understand, when do you really need to have the patient leave the facility for a cardiology follow-up appointment versus not?
That's often one of the questions that comes up is, does this cardiology appointment have to happen during the rehab stay, or can it wait until afterwards? How do you answer that question?
Yeah, thanks for that. So I think the most important thing, even when I'm seeing a patient as a cardiologist in a skilled nursing facility, there are things that are there are limitations to what can be done in a SNF. So, if there's a scheduled follow-up device interrogation that needs to be maintained after an implant, if there's required imaging after valve repair, that's going to be required within the time period of the SNF stay, post-surgical wound evaluations, those are sort of generally for patients who are more stable and can go to those appointments, and they should be maintained to make sure that the patient meets their so that their devices and their imaging is completed. I think in terms of clinical questions, again, depends on the comfort of the provider, but I think if a patient is failing to clinically improve, despite optimizing whatever therapies are available in the skilled nursing facility, and I say what are available because not all facilities have the same pharmacotherapeutics, not all have IV capacity, not all have all of the SGLT2 inhibitors on formulary. And I think if there are really adverse reactions or side effects of medications that deter clinical improvement, for example, someone is just really orthostatic and we can't get them to make any progress in therapy, but we know that their ejection fraction is low and they're supposed to be on sacubitril valsartan and all these other medications, but they're not making progress. What can we then do And should we run it by the cardiologist about holding it at this time? And I think, I can make that decision, but I think sometimes if you don't have expertise in cardiology, that's a little bit of a scary territory for non-cardiologists. And of course, any new cardiac symptoms that are hard to discern, they haven't had them, angina, palpitations, syncope, and arrhythmias that are new, I would definitely consult a cardiologist.
Thank you. That makes sense. We know that skilled nursing facilities are not built like hospitals. What challenges do you see for optimizing the management of heart failure in the SNF setting?
Yeah, so I think we talked about the fact that the patient, by selection to going to SNF is very ill. They tend to have multiple comorbidities, but beyond the fact that the patient is a high-risk patient, I think it's, the disease management that's necessary for patients is, in the idealized setting, is in the outpatient office or in the hospital, is simply not practical because of limited resources, unfortunately, in many of the SNFs around the country. Daily weight monitoring might be unrealistic because of staffing ratios, limited availability of nurses, limited physician access. Oftentimes, the physician is available once or twice a week, and they might just be available on call. There could be significant delays in ancillary testing depending on the geographic area, and lack of access to medical records. There's also, still to this day, I think one of the main areas that we need to improve on is the lack of heart failure specific training in skilled nursing facility staff, especially with the imperatives to improve heart failure management. A lot of this nurses, LPNs, and some even clinical providers aren't really aware of how to assess volume status in these complicated patients. It's not an easy thing to do. Historically, weight gain is regarded as a marker of improved hydration and nutrition. Heart failure medications, as I mentioned, could be held inappropriately. Indications for medications may not be clear. I see this all the time. And also, it's difficult when you have a culture in post-acute care of trying to make patients comfortable. Oftentimes, we're considering patients who are high risk for readmission, might have end-of-life conversations, might be unsure about palliative care preferences. And we're considering our main emphasis is making the patient recover and feel comfortable. And in that, acknowledging those liberties, we might have difficulty at getting patients and their families to comply with dietary recommendations. They are allowed to refuse medications. Finally, the skilled nursing facility setting in and of itself, puts patients based on just the logistics of sick patients being roomed together in tighter quarters. There's a high risk of infectious exposure. The patients are clinically complicated with cognitive impairment. And as we mentioned, there's often lack of specialty care for patients with multiple comorbidities.
There's kind of that ideal, then there is the reality, isn't there?
Exactly.
Well, how can we focus on avoidable rehospitalizations for patients with heart failure?
So I think, as Sharon mentioned, I think really following heart failure management with, assessing volume status, close clinical follow-up, examination to assess for new signs of heart failure are really important. But I think we really need to hammer home the concept that many patients with heart failure who are at risk for readmission are not readmitted actually for heart failure. And we know from large samples of patients evaluated with Medicare claims, millions of patients, that the majority of heart failure patients are not actually readmitted for the index diagnosis of heart failure. In fact, heart failure patients are readmitted for heart failure in only 1/3 of cases. And it's important to know that the timing of readmission for some heart failure patients could be within a week. So they could be discharged, they could be optimized, and then within a week or so, within, data suggests either 5 days up to 12 days are the highest risk period for readmission, all cause readmission for heart failure patients. And so, it's important to realize that they might not be admitted for volume overload, but an infection or pneumonia or renal impairment or COPD exacerbation. And so understanding that their heart failure readmission in some way, we just know, is a setup for readmission for other causes. And I think I like to reference this article in the New England Journal of Medicine by Dr. Krumholtz of Yale, who very nicely delineated this concept. And while there's no data to really sort of tease this out, I think a hospital admission for these very frail elderly patients selected for SNF admission might have sort of a vulnerability to other comorbidities based on their frailty after a hospitalization. And so the heart failure hospitalization is a marker of their illness that in the setting of recovery, they're susceptible to other comorbidities. And so managing and expecting that a heart failure patient might have a comorbid illness during their recovery period is an important piece of understanding how to reduce readmissions.
Well, we know that many patients with heart failure may have cognitive impairment as well. It could be due to delirium, dementia, or even both. I think it's important to just keep in mind that all this great education and reiteration we're doing for our patients, for their diet, teaching them how to check their weights, when to seek medical attention, it may not stick as well when there's cognitive impairment present. So this slide is a good reminder. Thank you for including it. Nicole, what are the key parts of implementing a heart failure disease management?
So I think, from a very high level, when a patient is admitted to a skilled nursing facility with a primary or secondary diagnosis of heart failure, doing a preliminary risk prediction of that patient. So you understand, is this patient at higher than normal risk for heart failure readmission or all-cause readmission? And there's some data to suggest what those markers are. Patients who have had multiple frequent readmissions in the past, patients with multiple comorbidities, older patients who are cognitively impaired, sort of understanding that risk. And then in using patient-specific monitoring, which I'll discuss further, having a focus on being able to to develop targeted and timely interventions, and developing, which I'll explain later, a comprehensive system of care. So to get more specific, some of the heart failure disease management program elements that I think are, generally, there's not great data on this, but should generally be considered or implemented, are having staff do daily weight assessments by a CNA or an LPN for at least the first 7 days after admission. And that is checking weights before breakfast, before their morning meal, and after a morning void. And really having systems in place to notify the covering provider for weight gain based on pre-specified parameters. It's important to monitor serum chemistries because we don't know how someone is going to respond to their diuretic dosing or the new medications that were implemented on hospital discharge. And understanding that when there is a change in clinical status, as we discussed, that can prompt whether or not it's an infection, it's worsening renal function, it's poorly controlled hypertension, it's a COPD exacerbation. Based on that comorbid illness, those patients might be prone to have either severe or mild, but at risk for decompensation of their heart failure status. So with any secondary illness, increasing the frequency of volume assessments, And of course, overarching based on the demographic of patients who are selected for SNF admission, who are older geriatric patients, most commonly, understanding their interventions need to be delivered within the context of patient-centered goals of care. So geriatric goals are not necessarily cardiac goals. And so whether or not our goals are to improve their functional capacity versus improve their mortality, most patients want to improve their physical activities, self-efficacy, independence, quality of life, reduce the risk of falls, but they don't necessarily want to live another 20 years. So understanding those goals, the competing goals between guideline-directed medical therapy benefits versus geriatric sensitivities to medication administration. And timely intervention, as I mentioned, is really important. Delaying treatment on patients who have a very tenuous volume status is risky because they can decompensate really quickly. They have sort of some of the patients, particularly older patients with HFpEF, they have very narrow volume targets. And so interventions need to be ordered and delivered quickly in the SNF setting.
You had mentioned earlier how our patients can change with their volume status or the symptoms of their volume status as they undergo therapy. What do you consider as best practices for working with our interdisciplinary team? And what should we watch for as people are participating in occupational and physical therapy?
Yeah, so I say the biggest thing is to listen to the therapist. And if you don't have a working relationship with them, if your SNF is one where therapy is in a different silo than the medical providers, try to bridge that gap, because so much of what we really understand about heart failure management in this geriatric cardiology population is elucidated during physical activity. And so when the therapist says, I'm not making progress, they're too dyspneic, they're lightheaded, they were pre-syncopal, we're really not making any functional goals, that's a marker for me to investigate further. And oftentimes that's a very different assessment than an LPN or a clinical medical staff who say, when they were sitting in bed, they felt great, their lungs are clear, they look good, they're euvolemic. So really understanding what's happening during exercise and incorporating physical therapy. And if someone's just in occupational therapy, sometimes even working on ADLs can elicit symptoms of suboptimal volume status. I think nutrition is an important multidisciplinary is an important discipline to work with, because oftentimes they know what's going on with their dietary compliance, and we don't necessarily know if a patient needs more education. And pharmacy, of course, can be very helpful in terms of helping decide what doses of medications and working with drug-drug interactions to make things more tolerable. And so I put in this slide, it takes a village to implement a heart failure disease management program, to really highlight that it's not easy. SNFs really do have a lot of resources, but we're not quite there yet in terms of developing an ideal model. But what I would recommend is, really emphasizing staff education. So from all levels, from LPNs up to medical directors, and the education on importance of risk stratifying heart failure patients and the importance for targeted monitoring and therapies for these very high-risk patients. Developing strong leadership, which, there's some data on, for example, heart failure champions or other physicians who take on a role of either managing heart failure specifically or being a targeted liaison between the medical staff and the outpatient cardiology office. I think one of the facilities that I work with, we engage in weekly interdisciplinary heart failure rounds where there is a selected staff member who looks at all the weights and all the vitals of patients who are admitted with heart failure. Their chart gets a red sticker, and every week, if there's an abnormality, it's flagged for me to see. And we round on those patients who we question whether or not they're still stable. As we mentioned, ancillary staff engagement is really a great tool if you can engage your staff. And of course, liaising with the community providers and the SNF providers is important.
It does take a village. Yeah. I think we talked a little bit about the physical therapy and the heart failure management. Did you have more to add?
No, that's it. I would say the one additional piece on this is incorporating frailty assessments into heart failure management and understanding that, the increased susceptibility to comorbidities with a frailty in patients who are frail is important. Physical therapy can weigh in on that if there's, they're recovering from an orthopedic surgery or, if speech or OT is working with a stroke patient, we can incorporate sort of their susceptibility to heart failure based on the severity of their comorbidity.
Well, we've been talking about people who are transferring from the hospital to the SNF setting. What about the patient who has completed their skilled rehabilitation stay and they're now preparing to discharge to home in the community?
So there are certain pieces that are really important to emphasize. I think the medication reconciliation is probably number 1, 2, and 3. We do often need to make changes in medications during the skilled nursing facility. One of the things that we see often is that patients go home and they resume exactly what the medication was at med list they had at home before their hospitalization and SNF stay. And we know that oftentimes they're hospitalized because they needed a change in their medications. Patient and caregiver education about how to monitor heart failure symptoms and optimizing their weight is really important. And I think that can be offered through as many channels as possible, from nurses, ancillary testing, and the primary provider. There's a big push to have heart failure patients set up in home health. I think if you can communicate directly what a patient's needs were or their symptoms, what their progress was like during the skilled nursing facility stay would be helpful. And of course, scheduling timely primary care and cardiology follow-up appointments. And communication needs to be seamless. So I'm a big believer in creating skilled nursing facility discharge summaries for all of the follow-up staff, which lists their medication changes, the reason for the changes, and their a summary of their SNF stay.
A lot of the information that our chat waterfall also produced. Yeah, wonderful.
So in summary, I think it's important to, for anyone who's managing a patient who's newly admitted from a hospital to a skilled nursing facility with a primary, secondary diagnosis of heart failure, to evaluate the patient's goals, to really enhance as best you can best practices for SNF staff following the recommendations that were highlighted in the beginning of the talk. Understanding that there might be a fair amount of reconciliation between geriatric goals of care and cardiac goals of care, and reconciling geriatric syndromes with the tendency to exacerbate those with guideline-directed medical therapy, and being aware that one size does not fit all. We really don't know how a patient is going to respond. We don't know if they're going to have a brisk response to the therapies, a slow response to the therapies, tolerability of all of the medications, both at rest and exercise, and to be aware that based on the complexity of these patients, we should be monitoring them closely, because the only thing that we can know for certain is that they're probably not going to be predictable. And of course, that the medical providers are available for multidisciplinary team engagement with the ancillary staff, as well as the community providers.
Thank you, Nicole. Excellent summary. And Sharon, do you have any final takeaways for our audience before we turn to the Q&A? You are on mute. Should use my moderator privilege.
I would say, like Nicole said, education of the SNF staff about what is heart failure, what symptoms should we be looking for, what medications are specific heart failure medications, and it would probably be the most important thing.
Right. I certainly learned a lot just preparing this webinar with you, and talking about this with our audience has been a really great pleasure. There are some questions in the chat box. I haven't been following along. Let's start with this one. The source, Nicole, of the study, or no, for Sharon, I think. What is the source of that study that showed readmission reductions with a phone call?
We'll put it in the slide. Well, it's going to be in the references of the slides. The author is Jacobs from 2011. So we're going to send the slides out and it'll be on the reference page.
Perfect. And what is the role of loop diuretics now? The physician in the chat box saying, I've used less loop diuretics when implementing GDMT. So Sharon or Nicole?
I'm happy to take that. That's a great point, and that's one of the benefits of these medications, because we know that loop diuretics treat symptoms, so they don't improve outcomes. And so having the added natriuretic and diuretic effect of ARNIs and SGLT2 inhibitors will reduce the requirement for loop diuretics. Again, we don't necessarily know how refractory a heart failure patient is to volume overload, despite optimal doses of SGLT2 inhibitors or ARNIs. And so there may be patients who still require high dose diuretics. It's every patient has sort of an individual profile, but you will often see that a patient, 2 years ago who was admitted for heart failure, or a year ago who was admitted for heart failure before they had initiation of these more novel therapies, may require less diuretics. And that is not unexpected. And if you can reduce the diuretic dose and just maintain the other therapies, which have additional cardioprotective benefits, that's recommended. What I wouldn't recommend, and I see this not unfrequently, which speaks to the need for more education, is that with acute renal failure, or with someone who's reached euvolemia or any other reason, or maybe hypotension, some providers will decrease sacubitril/valsartan before reducing their loop diuretic. So if someone has reached euvolemia, take off the loop diuretic before the other medications if you can, because the other medications will improve their cardiac function and reduce hard cardiac outcomes, whereas loop diuretics will just treat their volume of movement.
Thank you for pointing that out with our GDMT. And Nicole, how do you deal with this issue of the challenge of getting accurate weights, either in the hospital or in the nursing home?
So that requires leadership involvement. There is, it's not always possible. It is a labor of love, but I think there's a growing leadership buy-in to the importance of improved heart failure management programs and SNFs. And if weights are an important element, then the leadership will have in-servicing, teaching scale calibration. What I do personally is I write the order, not daily weights, but I specify daily weights before breakfast, after AM void. Sometimes you have to specify on the night shift before they leave home, so that you're not getting midday weights and diuresing a cheeseburger. So most of the time, I'm very specific about the timing and the sort of the setting of the weight. And I think that over time has been helpful.
And Sharon, what do you think about telemedicine cardiology appointments? First of all, are they feasible? And secondly, are they helpful?
I think it depends on the cardiology group, and some cardiology groups are going to be open to that, and then some may not be. I think it's going to be on a case-by-case basis. So they probably just have to reach out to the cardiologist to see if that's possible.
Mm-hmm. Thank you. And Nicole, you'd mentioned the readmission study in 2013. Do you anticipate that those results would look different now that people are on quadruple therapy?
So that was actually a summary paper published in 2013, but the original data was collected from Dr. Jenks, and I think it was published in 2009. So it is significantly older data, but there's more recent data about SNF-based heart failure readmissions, and that despite the fact that the therapies have improved, readmissions for heart failure really haven't budged that much, and they're still hovering around 25%. And it could be that the patients are more sick. It could be that because of legislative pressures, they're being discharged more quickly. But we still see a lot of patients who are readmitted, and they are oftentimes readmitted for reasons unrelated to their heart failure. I think we've actually done a really good job of managing in some of our skilled nursing facilities of managing their heart failure, and they're readmitted. They're so great that they're up and running around, and then they have a fall, or they visit a roommate and they get the flu, and so they're readmitted for other reasons.
There are so many different factors. Is fluid restriction necessary for heart failure patients?
That's technical.
What's that?
I'll let you take that.
So it's not a one size fits all. I think I'm going to answer this with a little bit of a sniff spin, that fluid restriction is not necessarily recommended. I always say to drink to thirst and do what you would normally do and let me deal with the rest. What is a problem is pushing PO fluids in someone who's dehydrated before backing off on their diuretics. Oftentimes we see someone who has a bump in their renal function, and the first response is to give an IV push or encourage PO intake. They have, the patient's still on Lasix 40, but they have all these pitchers of water, and it's just sort of, very inefficient use of the medication. And the first thing to do is to back off on diuretics. Fluid restriction in this population, I don't tend to recommend it unless it's an extreme circumstance of someone who has refractory symptomatic volume overload resulting, in pulmonary edema or weeping wounds, because they are often frail with poor nutritional status, and we're trying to optimize their quality of life. And I think in this particular population, dietary restrictions do not provide as much benefit that offsets sort of the risk of the patient's discomfort.
Nicole, would you agree salt restriction is similar? Like historically, recommendation was fairly extreme salt restriction, and that is no longer the case. Would you agree?
Yeah, the data is really ambiguous about it. I would agree for heart failure management. I do not recommend salt restriction. I do still recommend it for hypertensive patients who have sort of very difficult to control hypertension. And those are sometimes the patients who I'll say, okay, let's back off on how much we are liberalizing your diet. So for the blood pressure piece, I still would recommend it, but for managing volume status, I don't necessarily. I would adjust their therapies because, again, nutrition and quality of life are so important for these patients.
And along those lines, what does the evidence say about using laboratory work to monitor our patients' progress, specifically either basic labs or like a pro-BNP?
Yeah, that's a great question. So we don't have good SNF data. We don't have good data on SNF assessments of pro-BNP. And I think probably because there are so many confounding factors to the interpretation of the test in older patients with AFib, renal disease. But I if there is a baseline pro-BNP from the hospital, if there's a, sometimes getting for someone who is, admitted to heart failure, admitted with a heart failure diagnosis, getting a baseline pro-BNP is something that I might do if they were optimized in the heart failure in the hospital setting, and I know that they're high risk for readmission, because I would want to say, well, how will I know in the future if this patient is developing volume overload versus COPD exacerbation, because that's where they're constantly being sent back and forth to the hospital. So if I understand the prior clinical scenario, I might get a baseline BNP and follow that, or NT-proBNP. The basic labs are a comprehensive metabolic panel if you want to understand their albumin level, and if they had any evidence of hepatic congestion during the hospital stay. I do get a serum magnesium, because it's surprising that you can develop some symptoms from hypomagnesia from excessive diuretics. So repleting magnesium is important. Rarely on a long-term care patient who's very frail and weak and hasn't been seen for a long time by their outpatient cardiologist, and you're worried about drug-drug interactions or polypharmacy, I might, if someone's on atorvastatin 80 and they're 88 years old and they haven't had any recent cardiac events, I might check their lipid panel and deprescribe. And of course, if they're on triple therapy and it's anticoagulant therapy and antithrombotic therapy, and they're having symptoms and they were, I would check a basic H&H, but standard for everybody is serum chemistries and magnesium. And in other cases, on a case-by-case basis, I would add others.
Wonderful, thank you. I know there are several more questions in the chat box. Would you like us to keep going, or are we out of time?
Answer. Looks like we still have most learners hanging on with us, so you can take a couple of more questions if you have additional time.
All right, hearing no objections, we'll just keep going through the questions, which are all very excellent. Several people asked if this webinar is being recorded. Can they get the slides? Yes, and yes, we'll make all of this available to you. What about a situation where an SGLT2 inhibitor is causing UTI symptoms? Is there anything other than discontinuing it that it would be the right thing to do? And does the cardiologist need to know if that's happening? What do you think, Sharon?
I don't prescribe medicine. I was going to defer to Nicole.
Sure. So, it's a great question. And, the teaching is that it's not really urinary tract infections, even though there is this sort of glucosuria that you have to worry about that occurs. It's more the mycotic infections that, and the GU infections that happen in the skin and tissue that are more concerning. And so, sort of as a general practice, if a patient has had a UTI, they've been treated and they've recovered and they need the therapy for their heart failure, it's fine to start it and monitor them. I think I avoid it in someone who is, I avoid initiating it in someone with an active UTI, or someone who was has recurrent UTI, is admitted for urosepsis. You might want to be cautious. What I recommend in all of these older patients, whether they've had a distant UTI or a more recent UTI, is just enhanced GU hygiene. And the benefit of being in a SNF is that their aides are washing them, and you can actually, talk about it. You can say, when you shower, just be certain that you teach and focus on this area. And that is really the recommendation, is to increase GU hygiene as opposed to, monitor for urinary tract infections.
So maybe not a reflexive, just discontinue. Okay, yeah, thanks for those good tips. Are either one of you aware of some transitional care models that are focused on post-acute setting in heart failure? We know of models, the chat box commenter mentioned Project Red, which looks at transitions of care for people going from the hospital to the nursing home and trying to avoid avoidable rehospitalizations.
I'm not actually aware.
Yeah, I did read about this. I think it had I don't know the whole I can't speak about all of the logistics, but I think there was an integration of software. There was some integration of discharge documentation and integration of software between the SNF and the discharging hospital. And I think that communication piece did lead to reduced outcomes, particularly, reduced hospital readmission within 30 days. And I think, that's one particular piece. And if you think about what was the intervention, it's communication. And so I think communication between the hospital, SNF, and community providers, however you want to develop it, that works for you. I mean, it could be via software, it could be via telephone, it could be via appointments, it could be heart failure champions. I think we don't have enough large scale data to say, oh, this one is better than this. There's no randomized controlled trial that I know of that looks at telephone calls versus software integration and which one is better. But what we do know is that enhanced communication versus no enhanced communication, and whatever you choose for that enhanced communication will reduce heart failure readmissions. And, it's not really rocket science. It's just sort of understanding, what are the limitations to implementation. It's very hard to implement using the limited SNF resources. And so sort of figuring out where in the heart failure trajectory of the patient, which setting is going to be best employed for taking the lead in that communication is going to depend on a lot of things, where the patient is, how involved the primary care provider is, how involved the cardiologist is, how readily available case management or social work is, and just developing some sort of enhanced communication under the leadership of an involved medical director or primary care provider at the SNF would be my recommendation at this point until we have more granular data.
Well said. I think the PALTmed Transitions of Care group doesn't have a cardiologist. Maybe we should get one. Yeah. This next question, yeah, thank you. This next question, I'm not an Epic user, so I hope I'm saying this right, but it looks like there are ways to assess the risk of admission or readmissions with a score from Epic or perhaps whatever your EMR is. Do you prefer to use any sort of frailty index score or a different score to look at that risk?
At hospital discharge, we do look at the LACE score, but for heart failure patients, generally it's always high. Like all patients that are discharging from the hospital, if the LACE score is going to be high, that shows they're high risk for readmission. So it's not very good at determining a risk within that group. But I don't have another scale. It's more of an individual case. The patients that are resisting taking their medications, have a low health literacy level, that sort of thing, or is just from reading their chart, identifying that this patient's high risk for readmission based on those factors.
Probably a fair assumption. Good. There are a couple comments about telehealth after the follow-up, after a hospital for follow-up, about collaboration between the primary care groups and on-site rounding for cardiology. And here's another question. Access to ARNIs can be limited based on the patient's financial status, and it does add to the financial burden and also contribute to non-compliance. Are you aware of any initiatives to improve access to ARNIs at a national level?
So ARNI has, ARNI is going to be generic, supposed to be this year. I don't know if you know, Nicole, but I heard 2025, they're coming out with the generic. And then the pharmaceutical company that makes the ARNI does have a financial assistance program that patients can apply for. And they have to send in proof of income, and then they may qualify where the pharmaceutical company will mail them the medication on a monthly basis for free.
Good to know. There's a comment about fluid restriction and patients' right to non-adherence. And here's a question on iron levels. How often should we check iron levels when people have HFrEF? And what do you think about checking iron for people with HFpEF, preserved ejection fraction?
In the hospital, we try to ensure everyone has a recent iron level check, and we do give IV iron for patients that have low iron levels. Nicole, I'm not sure if you want to add to that, how the frequency of it. I believe it's every 6 months or so.
Yeah, so I think the issue, and I'm actually actively involved in trying and sort of trying to get our pharmaceutical reps involved with our skilled nursing facilities to make IV iron available in the SNF setting. Unfortunately, because it's not available on formulary for most SNFs, the testing in the SNF setting it's hard to know what to do with. You're going to have to send the patient to a follow-up cardiologist or a heart failure clinic. They'll probably want to repeat the test themselves before prescribing the medication. So I think the data is there was a recent review that calls into question the real efficacy of it, but I think it's compelling enough from a symptomatic improvement standpoint for patients with heart failure to treat. I have initiated this because the effects of symptomatic improvement are within 1 to 2 weeks if you receive IV iron, which is to me what goes off in my brain. Oh, well, a SNF stay is 30 days. So if I can get them walking better within 1 to 2 weeks, then they can improve their chances for community discharge, and we can decrease their SNF length of stay, which who doesn't want that, by improving their chance of reaching their therapy targets because they feel better. So I've looked into that. It's slow going. So at this point, there is no sort of standard recommendation for iron testing because we don't know what to we don't have the capacity in, at least in my SNFs, to treat the lab finding. And so at this point, it's sort of deferred to the hospital in the outpatient setting, but I am sort of working on it.
Oh, fascinating. Yeah, great initiative. There are a couple comments about affordability for these medications, as well as the dysuria related to SGLT2 inhibitors. And one final question. Some of the SGLT2 inhibitors are approved or are not approved for use in heart failure. Do you limit your use to those approved for heart failure, or use them all thinking that it's a class effect?
So I can speak on the affordability portion. So SGLT2 inhibitors and ARNIs both, we try to do prior authorization for those medications before the patient is discharged from the hospital. And a lot of times we'll find that they actually are not very expensive. Sometimes their copay might be $12. So so making sure that the prior authorization is done first, and then there is financial assistance for SGLT2 similar to the ARNI for patients that can't afford the copay even. And then the next part of the question, I think Nicole can take.
I stick to the guideline recommended therapies at this point. It's just my preference. I think that I think we following the evidence and hopefully replicating the outcomes in the large randomized clinical trials based on those medications. If they're not available, I guess it's a different question, but it's not my practice.
Thank you. I appreciate your perspective. Thank you both, Sharon and Nicole, for answering these questions, and our very engaged audience for bringing up these issues.
Yes, thank you so much, Sing, Sharon, and Nicole for sharing your expertise and taking some extra time to answer all these wonderful questions we've had coming in. We really appreciate it. As Dr. Pallett mentioned, the PowerPoint and the recording will be posted and available following this afternoon's webinar. You'll access that in the learning management system, so the same platform that you logged in to access the live webinar today. And a reminder that after we conclude, if you intend to claim credit, you'll need to return to the learning management system and complete that evaluation so that you can claim credit and receive your certificate. Again, thank you so much for joining us, and have a great afternoon.